Dr. Lynn Roberts is an academic and an advocate for women's and adolescent health in New York City. She's on faculty in the Community Health and Social Sciences program at CUNY, Graduate School of Public Health and Health Policy. Prior to coming to CUNY, Dr. Roberts was a faculty member in the Urban Public Health Program and affiliated faculty member in the Department of Women and Gender Studies at Hunter College. Prior to these academic roles, Dr. Roberts oversaw the development, implementation, and evaluation of several programs for women and youth in New York City. Dr. Roberts' current activism and scholarship examines the intersection of race, class, and gender in adolescent dating relationships, juvenile justice, and reproductive health policies, as well as the impact of models of collaborative inquiry and teaching on civic and political engagement. Since 2015, she's been a consultant to the New York City Department of Health and Mental Hygiene in support of their efforts to integrate a sexual and reproductive justice framework in their work. She was recently appointed to the Governor's Task Force on Maternal Mortality and Disparate Racial Outcomes for New York State, and is on the steering committee for the New York City Department of Health and Mental Hygiene Maternal Mortality and Severe Maternal Morbidity Committee. Please join me in welcoming her.
Good morning, and thank you, Liz, for inviting me. I hope I never have to follow after so many distinguished presenters, and hopefully this will be a bit of a change. As Liz mentioned, I have an extensive background and identify as a scholar activist, so this will be a bit of a different presentation, but I hope it adds to the wealth of knowledge that's been shared. So I want to talk about three concepts, or two concepts and a framework, and hopefully bring them together in my concluding thoughts or suggestions as we contemplate health equity, intersectionality, and reproductive justice. So what is health equity? I hope I don't have to explain this in this group, but I thought I would share one way that I try to make it clear to my students. You might have seen this image many times, courtesy of the Interaction Institute for Social Change, as an attempt to distinguish equality from equity. According to the CDC, as you know, health equity is achieved when every person has the opportunity to attain his or her full potential, and no one is disadvantaged from achieving this potential because of social position or socially determined circumstances. But this particular image has often been critiqued, and perhaps we need a more accurate depiction. Indeed, the previous image actually evolved from an earlier version in which the people presented were all white, and this one has been critiqued since it appears that people are all male. And still other critiques have been more inclusive of differently abled bodies. So with this reality of thinking that it's not just that people might not be able to see the ball game because of their relative disadvantage, but that some people have an even heightened ability to view the game, and others are very, as standing in that hole, a severe disadvantage. Still, I offer a critique that the image of a playing field with people as spectators in a sport in which they are not active players is problematic, even if it is a more accurate depiction. To achieve justice, the fence must be torn down to allow everyone the opportunity to play, and indeed, it might be a different game with new rules. So what is intersectionality? I was first introduced to the intersectionality theory through the writings of Bell Hooks in her 1984 book, Feminist Theory from Margin to Center, in which she described systems of interlocking oppressions work in concert to create inequality through a matrix of domination. and in which she acknowledges multiple social identities that everyone has, and calls upon us to center those who have been marginalized by privileging their unique ways of knowing the world based on their lived experiences. So as you see here, with that center dot referencing closeness or proximity to privilege and power and access to resources, you see those who are white, who are male, who are part of the ruling wealthy class, who are US born and English is their native language, who are able-bodied, who are more likely to be Protestant and Catholic, and heterosexual. But this is not at all exhaustive in terms of that proximity. And then those who are further in what we call the margins are defined as their distance or their identities being different than those in the inner circle. The theory itself, or the term intersectionality itself, was first coined by critical race scholar Kimberly Crenshaw, a legal scholar, and later expounded upon by Patricia Hill Collins in her seminal book, Black Feminist Thought, Knowledge, Consciousness, and the Politics of Empowerment, published in 1990. I will also note that there is a long history of intersectional analysis and organizing that predated the use of the term. From Sojourner Truth asking the question, "Ain't I a woman?" to Anna Julia Cooper reminding us, "Only the Black woman can say when and where I enter in the quiet, undisputed dignity of my womanhood without violence and without suing or special patronage, then and there the entire race enters with me." That was in 1892. To Frances Beale's 1969 publication Double Jeopardy, to Toni Cade Bambara in 1970 writing The Black Woman, to the Combahee River Collective Black Feminist Statement in 1974, stating that it is the synthesis of these oppressions that creates the conditions of our lives. Is it possible to get a bottle of water? Thank you. I'm very parched. Thank you so much. So with these two thoughts in mind, I do want to spend a little more time describing the reproductive justice framework. Reproductive justice, in my view, presents an opportunity for reframing women's health by bringing together both these concepts of health equity and intersectionality. So why reframe women's health? It's a direct response to reproductive injustices. The reproductive justice framework emerged as a direct response to centuries of reproductive oppression, and particularly for those who have been minoritized and marginalized through our bodies, our sexuality, our labor, and our reproduction. It is important to have a historical perspective. So in addition to the exploitation of their labor, enslaved women of African descent were forced to breed only to have their children sold as chattel. For those who aren't familiar, it was between 1845 and 1849 that the person considered the founder of modern gynecology, J. Marion Sims, experimented on enslaved African women and their infants without anesthesia that was available at the time to perfect surgical procedures that were largely meant or intended for white women. And we also have the context of the eugenics movement to increase births among those considered the most fit and to decrease births among the unfit. From the late 1800s until the early 1970s, Native American children were removed from their families and sent to boarding schools to, quote unquote, civilize and remove the Indian from them. And there have been numerous cases of sterilization abuse by the US government and medical institutions that have specifically targeted Puerto Rican women, both on the island and the mainland, African American women, and girls in North Carolina, or what Fannie Lou Hamer described as the Mississippi appendectomy. And Native American women on reservations, as well as Mexican American women in California. More recently, we have witnessed restrictions on comprehensive sex education in schools, the coercive use of contraceptives, restrictions on access to abortion, discriminatory early termination of parental rights, the separation of children from their parents through foster care and immigration enforcement, and the demonization and criminalization of pregnant and parenting women and girls based on our age, our substance use, and being poor. And I could go on. It is within this context of reproductive oppression that reproductive health inequities emerge, or I should say contribute. While we know that Black women are 3 to 4 times more likely to die of pregnancy-related causes than white women nationally, this racial ethnic disparity is higher in New York City than in the US as a whole. New York City's Health Pregnancy Associated Mortality Surveillance Report found that between 2008 and 2010, Black women in New York City were 12 times more likely than white women to die from pregnancy-related causes. And later surveillance reports that disparity has dropped slightly to 8 times more likely, but still a disparity. Reproductive justice is just one of 3 frameworks that has emerged in response to sexual and reproductive injustice or oppression. The other 2 are reproductive health and reproductive rights. I consider all 3 critical, and they are not mutually exclusive, but it is important to distinguish them. The 3 frameworks must often work in concert in order to achieve health equity and other human rights. The reproductive health framework emphasizes the necessary reproductive health services that women need, strategizes on improving and expanding services, research, and access, particularly prevention and cultural competency in communities of color or low-income communities. The primary constituents are patients and clients needing services and/or education, and it focuses on providers, medical professionals, community and public health educators, and health service providers more generally. It does have some limitations and challenges. For example, services and education are often directed at the individual level. The root causes of health inequities are often not addressed. It can be resource intensive without leading to long-term change. And it can be limited by inherent access issues because different people have varying levels of access to sexual and reproductive health services. The services may be fragmented and culturally unresponsive to their needs, and in some cases may even be harmful. The reproductive rights framework analyzes the core problem as a lack of legal protection, laws, or enforcement of laws that ensure an individual woman's legal right to reproductive health care services, especially abortion. The primary strategy is legal legislative advocacy at the state and federal levels. And people are organized to participate actively in the political process through the electoral system and encouraged to vote and call their members of Congress or state legislatures. The key players are advocates, legal experts, policymakers, and elected officials. This reproductive rights framework also has its challenges and limitations. The focus on individual choice obscures the social contexts in which individuals make choices, assumes a level of knowledge, access to elected officials, and belief in the effectiveness of the political system. People marginalized by their immigration status, their age, their class, their race and ethnicity, and disabilities often do not have this access, knowledge, or faith in the ability of the system to meet their needs. Reproductive justice, in contrast, aims to transform power inequities and create long-term systemic change, and therefore relies on the leadership of communities most impacted by reproductive oppression, and recognizes that all individuals are parts of communities and that our strategies must lift up entire communities to support individuals. And as defined by Asian Communities for Reproductive Justice, an RJ, a reproductive justice organization, now called Forward Together, They define reproductive justice as when all people have the social, political, and economic power and resources to make healthy decisions about our gender, bodies, and sexuality for ourselves, our families, and our communities. The term reproductive justice was coined in 1994 by a caucus of 12 Black women while attending a conference in Chicago, Illinois, sponsored by the Illinois Pro-Choice Alliance and the Ms. Foundation for Women. They formed Women of African Descent for Reproductive Justice, and I call their names. These founding mothers were looking for a way to articulate the needs of communities of color that face multiple forms of sexual and reproductive oppression, as I previously described. While the theory, strategy, and practice of reproductive justice have evolved over time, from the outset, the framework has been built in recognition of the need for an intersectional analysis defined by the human rights framework and based on the practice of self-help and community care that would be inclusive and applicable to everyone. There are three foundational elements, and the first element of the RJ framework is indeed intersectionality, in which we address the intersecting systems of oppression and health inequities. Intersectional analysis of the root causes of health inequities is essential to securing the human rights of all people. This is a repeat slide, and I'm just going to skip over. Sorry about that. The second foundational element is the human rights framework, generally defined as those rights which are inherent in our nature and without which we cannot live as human beings. They are universal and apply to all persons. They are not restricted to any protected class or group, and they are based on humankind's continuous and increasing demand for a life in which the inherent dignity and worth of each human being will receive respect and protection. There are 8 categories of human rights, and it remains true 70 years since the Universal Declaration of Human Rights that when these rights are threatened for any of us, they threaten all of us. The third foundational element is self-help, or what I also refer to as community care. Originated with the Black women's health movement in the United States, you may have heard of Billie Avery and her work with the Black Women's Health Project, now called the Black Women's Health Imperative. It was spread internationally by the National Black Women's, by that organization, and also the National Latina Health Organization. And it's also been used in the broader women's health movement by HIV/AIDS groups and amongst indigenous and women of color groups throughout the United States. Now that I've covered the 3 foundational elements, I want to speak to the principles of reproductive justice that clearly state the human right to decide if and when you will have a child and the conditions under which you will give birth or create a family. The human right to decide if you will not have a child and your options for preventing or ending a pregnancy. The human right to parent with the necessary social supports in safe environments and healthy communities and without threat of harm from individuals, organizations, or institutions of the state. And the human right to bodily autonomy from any form of sexual or reproductive oppression. So we carry these 4 principles into clinical practice as a newest endeavor, but also in movement building, policy advocacy. And these are the strategies I'd like to go over very quickly. One is that we analyze and work to change unjust systems of power, and I can think of no finer example of this strategy than the Black Mamas Matter Alliance for their work to engage in research, policy, and culture shift informed and led by and for Black women. When necessary, we take direct action, And I define direct action as confrontation that, if successful, ultimately leads to negotiation with those in a position of power to make decisions that will address the root causes of a social injustice. A third strategy is to recognize and support the leadership and power of those most excluded groups of people within a culturally relevant context that identifies and addresses the multi-layered impact of oppression on their lives. And by centering, going back to that earlier image where we had the margins and the center, we're taking those folks from the margin and pushing them towards the center. We do this by providing sustainable long-term funding, supporting capacity building, consulting prior to and not after new initiatives, bringing folks to the table when making decisions that will impact them, sharing resources, sharing the credit, and educating ourselves and practicing being better allies to others. I say that all of us can be an ally to someone else because all of us have varying levels of privilege and disadvantage, utilizing an intersectional framework. And so when my own status as a Black woman and of educational privilege relative to someone else, and also as an able, well, depending on the day of the week, and mostly able-bodied person, I often need to educate myself on how to become a better ally to those who don't share those statuses. So I include everyone in that. It's not, we can't reduce our identities to single categories. And that, again, is why intersectionality is so crucial here. Another strategy is to develop the leadership and build the social, political, and economic power of those most impacted and their communities so that they can survive and thrive. We do this by listening to, engaging, and mobilizing communities most affected by sexual and reproductive oppression to address the issues of concern to them. And we create opportunities for new leaders to emerge. We also coalition build and support a network of allied social justice organizations who integrate a reproductive justice analysis and agenda into their work. These could be organizations focused on human rights, civil rights and racial justice, LGBTQ rights, environmental justice, workers' rights and labor unions, faith-based organizations, housing rights, immigrant rights, single-payer healthcare reform, sovereignty issues, and I could go on. We also strategize in recognition of the potential for radical transformation through reproductive justice can alarm or make cynics of many across the political spectrum. We educate our current electeds about reproductive justice, and we groom and support new candidates for office. We also encourage voter registration, educate the public on the issues, and we fight against voter suppression. If anyone paid attention to the State of the Union address last week and the response from Georgia candidate Stacey Abrams, she did say reproductive justice that came as the result of years, I would say even decades, of organizing in this capacity. And still another strategy is storytelling. It is through storytelling, or what I call we-search as opposed to research, we reveal stories of human rights violations, acts of humiliation, violence, and exclusion. And this validation of a person's humanity acknowledges the whole range of emotions that can be experienced and uses self-disclosure to initiate healing and also collaborative processes of restoration. My throat is so dry, I'm not sure why. So connecting the dots, what will reframing women's health with a new lens require? First and foremost is to listen and amplify the voices of those who have been most impacted by sexual and reproductive injustice and health inequities, and to turn to them for solutions. To do this, for example, if we are centered, we being those who have been marginalized, are centered in the data, especially the disparities data, which we often are, we should also be centered in the decisions made to address these disparities and the resulting health inequities. To do this, it's important to understand the historical context of the control of indigenous, immigrant, and differently abled women, LGBTQ people of color, sexuality and reproduction, and its consequences on their health and well-being. To listen and respect their self-determination and bodily autonomy, to practice humility and take risks toward deeper engagement with those who are most marginalized, to join and collaborate with organizations and coalitions led by those who have been marginalized, to be an informed citizen, a voter, an ally, an advocate, an accomplice, or an agitator, to listen and read the writings of those who are indigenous, immigrant, differently abled, women, LGBTQ, and people of color, and to reflect and work to transform any institutional policies and practices that impede reproductive justice. So what does this look like for us as researchers? I think it's important to reconsider our epistemological assumptions, or how we know what we know, through exploration of critical theories that consider the complexity of the structural systems that produce and sustain health inequities. Irrespective of our methodological preferences, we might ask ourselves if we are more positivists than constructivists, for example. We can also, can and should strive to engage those most impacted as co-researchers at all points in the research process. Intersectionality presents a unique challenge to women's health researchers. We cannot expect to use existing explanatory models for determining evidence alone to capture its complexity. I would argue that the more in-depth we can become, the more longitudinal and reflective in our research methods, but I'm open to bringing all the tools of science and evidence gathering to bear on attempting to do this. And there's some researchers in particular who have, begun to tackle intersectionality, which emerged again in legal scholarship and has also been very much a part of discussions in the past decade or so. I'm thinking of researchers such as Lisa Bowleg, who has explored a lot around HIV and AIDS. And I also think of the critical race application of critical race theory by public health scholars Chandra Ford and Colin Erhing-Hambua. So again, still a bit in the nascency of doing this type of research, and it's clearly more exploratory. I myself published a paper in Ethnicity and Disease in 2018 exploring intersectionality in adolescent dating relationships. And again, it's more of an invitation for those who are embarking on research in women's health for the first time to consider this as something to dive into, and it would be much appreciated. And finally, too often researchers become embedded in niches of expertise that merely describe disparities but do not contribute to their eradication. And I caution folks to get too wed to the descriptive piece of disparities and health inequities in their research. We need to do more studying up and not down. Imagine sharing insider knowledge or emic analyses to probe the conditions that contribute to discriminatory practices in medicine. Perhaps we need more studies of the knowledge, attitudes, and behavior of people in white coats that may contribute to those health inequities. And let us be the ones to create new rules in a new game and towards reproductive justice. And finally, I just leave you with some suggested texts for women's health practitioners and researchers to consider. And I'll take questions.
Thank you very much for your talk. First of all, I think it's really nice to see kind of Audre Lorde and Bell Hooks and Kimberly Crenshaw talked about within the clinical space, because I think that you don't see that very much. And so I appreciate you bringing their scholarly work to light. I was trying to think a lot about how to connect the dots when it comes to the different talks that we've had thus far, and kind of where yours sits. And it seems necessary to think about, you kind of mentioned it towards the end, but thinking about how you integrate these discussions of reproductive health, reproductive rights, justice, equity, et cetera, into the discourse, into the clinical discourse. And especially as we're thinking about risk, as we're thinking about all of these other things, and even when we're thinking about what options as clinicians, I'm not a clinician, I'm a biostatistician,
Okay.
but what options in terms of treatment women are given based on what the understanding of risk is. And it seems like this conversation in terms of thinking more about how the patients are contributing to solutions means that what may at times seem like a rational decision for a clinician may not be the rational decision that the woman or the patient is going to take, given all of these other factors. And so I don't know, maybe I'm saying a lot, but I'm just trying to wonder if you can talk a little bit more about how you integrate what you've discussed into the clinical care of the women, especially given the talks that we've had thus far.
Well, a lot of the work is happening right now in education of the workforce of physicians. So Grand Rounds presentations is one way in which we've begun to have those conversations. Just having community members sit on the maternal mortality review committees is another opportunity for conversation. So when we examine all of the maternal deaths in New York City and review those cases, just having different folks consider the context of the lives of that lost life is another opportunity. But I think it can happen in any opportunity we have to talk about women's health is an opportunity to have these discussions. I think the framework is helpful for us to think when are we bringing those principles to bear, and the whole patient-doctor relationship about I know there's this concept of shared decision-making, to think more about how we are to actually respect the decisions people make, but we have well-informed them based on the evidence that's available to us, but then allowing that they also have the context of their lives in which they have to reckon. So all of the studies that were shared earlier, I would love to have further conversations with each of the presenters, because I think they each present unique opportunities for further exploration and discussion. And I think some of that discussion is already, happening within the clinical context. I think it's just broadening it, and about who's a part of those discussions is really important. And feeling that we can trust that there aren't any absolute answers. We will raise more questions and hopefully come up with solutions that matter in people's lives, because none of us has the magic bullet that's going to improve everyone's health as much as we would like, but we can explore how we shape the questions, the research questions, and the analyses according to how we have considered other possibilities, because all of us have the ability to probe and query, and some of us have different skills and levels of understanding of how we generate different types of evidence. So again, it's all about broadening the conversation and being able to consider that, like it was bringing the whole context of historical oppression into determining that, racism causes harm and allostatic load. That all came from similar evolutions of thought and inclusion of people holding those conversations in those spaces and challenging the status quo in striking ways. I noticed we talked about women a lot. Many of the studies, when they talked about women, what women are we talking about, right? So intersectionality would suggest that we have to think of women in all of their, realities. And so we can't just say men and women, because not all women have had shared or similar experiences historically or in the current context.
It's really exciting for us today to we spent a lot of time thinking about the different speakers and the topics. Our planning committee thought about what we wanted to introduce for our inaugural symposium, and we wanted it to be broad, we wanted it to be stimulating, we wanted you to go outside of your comfort zone and think about things in a different way and realize that women's health research is broad and that there are a number of investigators from a number of various backgrounds who are trying to tackle this and improve the lives of all women and improve our quality of life. And I think today's speakers, I would like us to sort of give them another round of applause, because they were wonderful. From mental health to the genetics of ovarian and breast cancer, to the history of women's health in this country, to hearing about pregnancy as a window for future life, to sex as a biologic variable and thinking about sex differences. It's just been an amazing morning, and I'm so, so thrilled that we pulled it off, and thank you guys all for sharing this with us. I would just like to end by thanking the staff who have done a tremendous job in organization and getting this day. Naisa, Ashaki, Amy, Heather, all of you guys have made just a tremendous, all of your hard work has paid off, and I really want to say thank you to you. I want to also quickly say a huge thank you to Dr. Michael Brodmann, who's the chair of obstetrics and gynecology and reproductive science, who has been a true partner in this effort of building this institute, who, talks to, I'm nonstop about this institute and what we can do, and he just has been a huge champion, and so I want to give him a round of applause as well.